To do a breast self-examination, follow these 3 steps. Check for any visible breast changes with your arms at your sides, overhead, firmly pressing your hands on your hips and bending forward. With a pillow under your shoulder, make small circles by pressing down on the collarbone, moving clockwise towards the nipple. With your arms raised, check your breasts with the soapy hand and fingers, using the same technique as lying down. Repeat these steps on both sides.
How can a woman tell if she has breast cancer? And what are the possible complications of breast cancer? Can breast cancer be life-threatening? And what happens when you let breast cancer go untreated? Hello and welcome. I'm your host, Dr. Musamtomene, and signing with us today is Fortune Madlala. Today in Vital Signs, we focused on breast cancer and the complications of breast cancer. And coming up in the program, we speak to 2 women who are affected by breast cancer. We speak to a top breast cancer expert in South Africa, specializing as a surgeon, about how the pandemic has affected the way that we approach breast cancer care. And of course, we'll speak to a physiotherapist and certified lymphedema wound care specialist about the complications of breast cancer. Zama Buthelezi will then update us on the latest South African COVID-19 numbers, and we wrap things up at the end of the show with Dr. Marlon McKay, who will answer your questions about COVID-19. Remember that you can be part of the show by asking our guests some of the questions that you have on your mind, or simply sharing your views about what we're discussing today. The number to call is 011-714-5861 or 011-714-5877. You can also share your thoughts with us on social media using the social media platforms that exist, such as Twitter at SABC Vital Signs, as well as our Facebook page, SABC Vital Signs. Vital Signs continues right after the ad break, as we'll be speaking to a woman who recently got diagnosed with breast cancer, and of course we'll speak to a leading breast cancer specialist. Stay with us. Welcome back. This is Vital Signs. I'm Dr. Musamtombene, and today we're talking about a very important issue, especially during Women's Month. Now, while many people are aware of all the issues surrounding COVID-19, many people are unaware of the struggles that come with breast cancer, such as early detection, access to treatment during COVID-19, and many other issues. Someone by the name of Debbie Ngoma was recently diagnosed with breast cancer and underwent surgery, and she's now recovering at home, and she joins us live to share her experience with us. Good morning, Debbie. How are you this morning?
Good morning, Dr. Musa. I'm fine, thank you. And how are you?
I am well. Look, it's such a great thing to hear about stories from survivors, people that went through the trauma of being diagnosed, went through the trauma of the treatments and the management that they have to face, and coming out at the end, sitting here chatting with us. So thank you very much for giving us this opportunity. So let's start at the very beginning. You're sitting at home. The next day, news changed because you've just received a diagnosis. Let's chat about that. What happened and what made you go see a doctor?
Okay. I was just lying in my bed, I would say, touch my body, because I didn't feel anything, but I was just playing with my nipple, touching my breast. Then I realized that there's a lump in my breast, but it was not a huge thing, but it was something that is not supposed to be there. Then I tell my children, especially my daughter, then she says, you need to check this. You need to take care of this. And I was like, okay, I'll go and check it. And I kept postponing. Then one time she said, you need to go and check this because you can't sit with something you don't know. Then I decided I'll go to the local clinic. Then they referred me to Charlotte Maxeke Breast Clinic. Then when I got there, the doctor asked me all the relevant questions. And I said no to most, in fact, almost all of the questions he asked me.
Questions such as what, Debbie?
Such as, do you have a family history of cancer? No. Is there any liquid or fluid coming out from your breast? No. Is your breast sore? No. Almost everything was no. So I was so definite that this is just a lump. It's just something that's going to vanish and maybe just be removed. Then I continue with my life. But he said, I want you to go to a scan. I went for a scan. while the doctor was doing the ultrasound, she says to me, you know what, I'm a bit concerned about this lump. Can you permit me to do a biopsy? I said, do the biopsy. I gave her the consent to do the biopsy. Then I left. I come back for the results, knowing that I'm fine. Nothing is wrong with me. Then I'm sitting there with the doctor who was telling me the results. And she tells me that the lump is cancerous.
Sure.
I was so calm about it, but I will give the credit to prayer because God prepared me in advance.
Okay.
When I went there, I was in a prayerful mode, even months before, and worship mode. So I was sitting there, and she looked at me and said, yo, I'm so surprised. You're so calm, and with such news, I'm so happy that you are taking this the way you are. But in between, I would be like, is this really happening? Am I dreaming? And then I asked her, what will be the next step if you say this is cancerous?
For sure.
Then she told me that the doctors are going to deliberate and see what treatment they will give me.
So what treatments did you get, Debbie? What treatments were you given?
At that moment, there were 2 doctors who were around. They also came and checked, and then they said it's either they will do chemo first, and then remove the breast, because the sooner they remove the breast, the better. Because my cancer was a slow-growing cancer, and also it was a very, very early stage. So they said the best thing to do is to remove it. I was also at peace with that, because I said, if this breast is going to bring trouble for me, I might as well just take it away.
For sure.
So that I can live my life longer.
For sure.
Because I believe that if the doctors are saying this is the best way, yes, I will also do my research and also deliberate with my family. But within me, there was that peace that says this is the right thing to do. Then I went home. My son was picking me up on that day. Then I tell him that they're gonna remove it. But I think I confused him because he was excited, yay, they're removing the lump, not knowing that they're removing the whole breast. Then I had to explain to him that, no, the lump is cancerous, they're removing the breast. Then he started getting sad and starting consoling me. Then he said, don't worry, mommy, this is our journey. We're gonna walk with you.
We're gonna walk with you. Wow. You know what I like about that is that, you know, you've introduced a different aspect. So, I mean, I'm a doctor and I know other doctors see things in a different light. We always see disease or ailments or cancers or whatever it might be as these things that happen to people in the sense that you get the disease, we're going to treat you, you go home. Whereas you've brought in this sort of familial, family, but also, you know, supportive element to it. Well, listen, Debbie, I'm sorry I'm going to have to cut you short, but I think this experience that you've told us about is very important because it highlights the importance of things that you've just mentioned, things such as self-breast examination, things such as, you know, preparing yourself mentally for a worst case scenario, but also a best case scenario. So thank you very much for joining us this morning, Debbie. And that is Debbie Ngoma, who is a breast cancer survivor, giving us her short story about, you know, what she experienced, what she went through when she was, you know, diagnosed with breast cancer. And I'm sure there are many, many other stories that are like that. Now, I'm sure you know that we're going to speak to someone, of course, and a doctor is someone that we bring on the show today. And people have been diagnosed with breast cancer, people that are, you know, normally noted as people having high risk for having these breast cancer, find themselves having very, very difficult times whilst trying to get treatment during this coronavirus pandemic. You know, people and access to those sort of things was difficult. People were unable, for instance, to get into a space where they could go to a clinic, go to a local clinic, go to a hospital, go see their doctor because either restrictions are there, you can't walk around, you can't visit facilities and things such as that. And of course, that's had an impact on people getting health. Well, we get to speak to Professor Carol Ann Ben, who's a specialist surgeon and breast disease specialist, about COVID-19 and how it sort of laid the ground for where we find ourselves at this point in time. So good morning, Prof. How are you this morning?
Hi, it's always an honor and a privilege to be on the show. And I'm going to use COVID, but also use the story of our lovely cancer survivor to explain a couple of things. So firstly, 65% of women who get breast cancer have no risk factors, exactly like we saw from the lady who spoke before me. So the importance of knowing your body, being in touch with your body, literally, and if you've got a problem, how do you seek help? Now, SARS-CoV-2 created certain barriers to healthcare. In that, people were nervous to access healthcare services, or they didn't know process. So we had to adapt. So nice things, for example, at Helen Joseph, we still had our walk-in clinics twice a week. We had people socially distanced. But what we did is we encouraged people by the digital media not to come in for routine screening, to come in if you've got a problem. So what we're trying to do, and this is a good thing actually throughout the world, is if you are concerned, access healthcare. But if you are for screening, we need to have different systems about how you screen for cancers. The next important issue is that our lady before me spoke about the fact that hers was a lazy cancer. Now, what SARS-CoV-2 did, it changed the concept of personalized oncology care. It stressed the fact that diagnosis of breast cancer is made by a radiologist with a needle biopsy. And again, these services are available in state and private. So check the financial cost implications before you go ahead and do things. What it taught us is that breast cancers are slow growing. Do not rush into treatment.
Prof. Ben?
And you should have a multidisciplinary treatment. Decision-making, yes?
Sorry,
yes?
we lost you there for a second,
Hi?
but you can continue.
Okay, so the concept is that you want a multidisciplinary treatment process before you rush into treatment. So in terms of slow-growing cancers, throughout the world, we actually didn't start by operating on people. We started by putting them on endocrine treatment and shrinking cancers down, okay? We worked out that less people needed things such as chemotherapy, and we had a more personalized approach. Mostly we don't do mastectomy. 7 out of 10 ladies today do not require their breast off. It's often choice, or if the cancer's sitting under the nipple, or you've got a small breast. But most people today, we do between 5 and 10 breast saving operations at Helen Joseph. So you ask your doctor, and taking the breast off doesn't result in you not needing oncology treatment. So we treat the cancer as per their personality, their behavior, and we also look at working out what's best for the person. We did a whole lot of things such as virtual scripting for patients, virtual information, because SARS-CoV-2 has created anxiety, which for all of us. So what I have learned every day from my cancer patients is they understand the fragility of life. For many of us around SARS-CoV-2, this was a novel concept. We didn't know who was going to live, who was going to die. And I think we can learn a lot from the braveness of our cancer patients. What the other thing is that we saw more advanced cancers coming in. And I don't think it helped the fact that we had hospitals burning down and change of facilities from a government point of view. But the values that the positives came out is that we had more digital online doctor communication processes. Did not rush people into treatment, so they had an understanding, the concept of consent. The lady who spoke said consent. She consented for the biopsy, and I think that's important. Remember, 9 out of 10 people with breast cancer, if picked up early, are alive and well 10 years down the line. So we want early detection and a multidisciplinary approach. What we also learned is the fact that communities are so giving. So behind me is an amazing picture. So what people have done is this young photographer, for example, gives a process donation to things like Women's Health, Say No to Violence. People have given so much. The value for me from SARS-CoV-2 is we've seen community spirit, and South Africa is so good at that, you know, helping out people, working out transport to oncology services, making sure that we were looking after people. And that's the thing about breast cancer that we've really seen around SARS-CoV-2. We have navigators in the clinic and online to navigate people through the cancer journey. Concepts of what do you do if someone has SARS-CoV-2 and is on oncology treatment or on radiation. So I walked into one of the radiation oncologists, phoning all the people who were SARS-CoV-2 positive, who had step-down delays in their treatment. So those type of things have been set up. So the concept of moving forward, now I'm not very techno, but technology has helped with this viral pandemic. And what we have realized is we've had more teamwork around managing breast cancer patients. Yes, it's been a battle with having people having to have test results to come into hospital to have their surgery,
For sure.
delay in surgery. But I think by and large, we've learned a lot out of it, and we salute our cancer patients who've had a harder journey at this time. I don't know if you've got questions.
Of course. Prof. Ben, we'll continue our discussion after the ad break, but I think you're highlighting so many important points here, that there is good and there is bad. I think there are so many elements where we find ourselves being pushed into situations where, you know, we're moving into a digital space because we're being forced to be in that digital space because of the pandemic, and of course all the barriers that came with it. Do not move a muscle. We're going to an ad break. When we come back, we'll continue our discussion with Prof. Ben. Welcome back. This is Vital Signs on SABC. And of course, we're talking about breast cancer. It is Women's Month, and we've got one of the experts, one of the more popular people that you may know about. And this is Prof. Carol Ann Ben. And we continue our discussion with her. Prof, let's continue our discussion. Something that you mentioned before we went to ad break was an issue of screening, that during COVID, patients were told not to come in for routine screening so that they could, you know, assess and be seen and things such as that. But what are some of the big things that people need to look out for at home, but as well as at facilities where things need to be done right?
So you bring up a really important aspect. So I didn't screen last year. Most people throughout the world, they said, don't come in for your screening. What is screening? Screening is when you don't have a problem and you come in for your radiology. So the fortunate thing is what we've had already set up at Helen Joseph, this concept of triage screening, which the whole world is going to. It means that if you have a problem, you need to be able to access healthcare. So if you have a lump, we put you as a red triage, and still you will have your mammogram and ultrasound and a needle biopsy within a week. Okay, so that should happen to everyone. So the problem around the pandemic is when people were under lockdown, they were scared to come in. So they often left their lumps saying, oh, should I come in? Maybe I can't. What if it's not? So we need to be clear that if you have a problem, you must seek help. Then people who had breast pain or maybe a nipple discharge or something that didn't look concerning or suspicious for a cancer, we triage them as a yellow. So we say, come in and we want to screen you, but not as urgently. And then people like myself or everyone else who do their breast examination don't find a concern. It's a green triage, which means you should come in and we screen you. We do your mammograms. You see a doctor once a year, your mammogram and ultrasounds every 2 to 3 years. So that's important. So we want to make sure that people understand that even if they're scared of the hospitals, I often say that there's more people are catching more SARS-CoV-2 out in the communities than there are in the hospitals, where there's attention to cleanliness. There's more people are fussy about mask wearing, cleaning down of services. So I have an amazing cleaning team at Helen Joseph, who unfortunately was off last week, but we really worked well. We put screenings up for the admin staff, and a big kudos to my admin staff. Since March last year, I haven't had one COVID incident with any of the staff at all. It's amazing, which means we could run a service. But these were issues. There were problems with hospital beds, numbers, so that if you've got large numbers of COVID patients, you can't admit your cancer patients. Obviously, oncology point of view, to watch social distancing, COVID tests or symptoms in people getting chemotherapy, you have to be very, very careful.
For sure.
A lot more of these we put on hormone block treatment and not chemotherapy. And or we became more personalized in our oncology care, which I think is not a bad thing. We set up cryo, freezing cancers, the future, because of the need with SARS-CoV-2.
Prof, we'll discuss more of these future treatments and the way forward with respect to, you know, the services that people can access. But we've got Sean from Gauteng who's got a question for you. Good morning, Sean.
Good morning, team. Good morning, Doc.
Good morning.
Doctor, my question is, can I carry on?
Yeah, of course.
My question is, I had a breast reduction in 2008. And what happened that same day when I was discharged, I just was very busy in my house. So 2 stitches came out, but I didn't go back to hospital so that they could re-stitch it. And what happened with that stitches, it made a sort of a hard bore around that place now. So 5 years ago, they sent me for to put a needle inside and they took some liquid there. But since then, I never went back for mammogram. I'm 52 now. I never went back for mammogram because I'm so scared of this putting the needle in. And the other thing, I'm scared it might cause cancer. So I'm not sure whether it will cause cancer. But there's nobody with breast cancer in my family. There's no cancers in my family. So on the other hand, I keep on thinking maybe I'm safe. There will be no breast cancer. But please tell me, Doc, can I go for a mammogram? Can I go for the needles, or is it fine? Can I leave it?
All right, Prof?
So, ma'am, you bring up a whole lot of important issues. So, firstly, what happened around your breast reduction is the area is called the angle of sorrows. And if the stitches come loose, you get a fat ball, an area of fat necrosis or fluid. So, we're going to encourage you to feel your breast and go for your mammogram and ultrasound. And just because you've had a needle in before doesn't mean to say you're going to need a needle in again. And remember, like that lovely lady who started the show, 65% of all people who get cancer have no risk factors. Do not be scared of going for your mammograms. Do not be scared of examining your breast. Not everyone needs needle biopsies to pick up things, but routine checks are important. So thank you for the lovely questions.
All right. Thank you so much. That was a call from Sean, but I'm assuming that isn't Sean, naturally. Prof, we've run out of time, but thank you so much for joining us this morning to really highlight all the obstacles and all the good things that are coming out of COVID. And hopefully your clinic gets back up and running again to 400% so they can get back to seeing everyone.
We're fully 100% and have been all the way through. So if you're a new patient, you come on a Tuesday to Helen Joseph Breast Clinic. If you think you've got a cancer, come on a Thursday between 7 and 9, and we're happy to help.
There we go.
Take care, guys.
Thank you so much, Prof. And that is the discussion with our breast cancer expert, and that is Prof. Carol Ann Ben, who really discussed all the big things that happened, COVID and all the effects that it's had on us and the lives that we've lived, especially for women who thought or might think that they have a breast lump or something along those lines. Do not move a muscle. We're going to an ad break. We'll see you after this. Welcome back. This is Vital Signs. I'm Dr. Musam Tombene, and we're talking about breast cancer as well as the second part of the show where we're looking at lymphedema. Now, this is a condition resulting in the abnormal, debilitating swelling of the extremities. And of course, that follows after many different pathologies. But of course, it's noted in breast cancer or post-breast cancer surgery as well. Now, approximately 30% of the 2.4 million breast cancer survivors have developed lymphedema. And of course, psychologically, survivors often feel stigmatized because of the swollen limb and often bring a number of things, such as anxiety, depression, and of course, the interpersonal relationships also get disrupted. Now, we are going to speak to Mimo Mogosi, who is going to speak about the impact of living with lymphedema. Let's welcome her to the show. Hello, Mimo.
Hello, how are you?
I'm very well, thank you. Now, you're a very popular person on social media. Every time someone sees your picture, they say, hey, I know about this girl. What does she have to say to us today? But let's talk about how you got popular. Apart from being someone that is obviously alive with possibilities, you're someone that isn't very shy about sharing their story. So tell us your story very quickly.
Oh, my goodness. I won't say I am. Well, people like to say that I'm popular, but I don't think I'm popular. I'm just well known. So I'm well known for sharing my health journey, and I know that a lot of times we say that it's stigma and people do not want to share what they are going through, but I changed my health into inspiration and giving hope.
Okay, so you've turned your story into, giving hope like you've highlighted, but when you were told that you've got lymphedema, what did you think was going on? What were the symptoms that you were experiencing at home before you realized and got the diagnosis?
So at first, I remember calling my doctor because I'm a post-liver transplant patient. I said to him, there's something weird happening with my leg. It's going bigger, and then the next minute it's back to normal. So it was just swelling and going back to normal. And when I went to go and see him, it was normal. So I was like, I'm not mad. I know what I'm talking about. And of course, I have such an amazing transplant team. My doctor actually said, I know what you're talking about, and it could be lymphedema, but you just need to do tests. So the day that I went back to the doctor, it was big and it wasn't going any smaller anymore. So I did a lymphatic scan, and the test came back positive. He said that I had lymphedema. So at first I didn't even know how to pronounce it. I was lympho, what? But it's just going bigger. Yeah.
Okay, so you get this diagnosis and now you need to get back to living life, whatever that may mean to you at that point in time. What was your plan of action? Was it one of those things where you started realizing that maybe, playing soccer might not be the best thing I can do right now, so I might need to stop that? Or did you just decide, you know what, this is my life to live still and I'm continuing with it?
I think because I'm such a positive person, I told myself this is not a disability and it's not going to restrict me from doing anything. Well, at first it did restrict me from wearing jeans, but now I do. And because there is not much treatment and it is not well known, we're still investigating what caused the lymphedema. We think that it could be Repamine, one of the pills that I used to take post my transplant since I injected Progress. But you know what? In my mind, I'm still normal. And only when someone mentioned that, actually, what's wrong with your leg? I'm like, but what if it's right? And your leg is not supposed to be looking like that.
Well, listen, Mimo, thank you so much for joining us this morning and really sharing your journey. I think, having case studies of people like you that have really gone out, experienced what they have experienced and, going out and sharing this really opens up this discussion around different, body things that happen to people so that people can go out and actually find out from, doctors and whoever it may be about what's going on with their bodies. I mean, there is no cure for lymphedema, like you've mentioned, but you have said that there are treatment options that exist as well. So thank you for sharing your story with us. Now, still speaking on this, of course, we're talking and we need to look at other things, and these things are things such as treatment. And of course, we have to focus on reducing the swelling and controlling the pain of this. Now, lymphedema treatments include a number of things such as exercise, wrapping that leg or arm or the part of the body that has the lymphedema, amongst the many, many other things that happen. And of course, there are other things that we'll look at as well. But more details, of course, need to come about when we look at treating lymphedema. And we're joined by Sue Cerebro, who is a physiotherapist and certified lymphedema and wound care specialist. Welcome to Vital Signs.
Hi, welcome. Thank you.
All right, so let's talk about how you deal with lymphedema. So this is something that a lot of people actually find themselves having to deal with, whether it's temporary or something that has acutely come on. But as a physiotherapist, how have you found yourself having to deal with these?
Okay, so a patient is referred to me by the oncologist, radio-oncologist, plastic surgeon or surgeon. And the first treatment is more or less a verbal assessment, because we found that it's very important to assess the patient briefly, because lymphedema presents itself differently in every patient because there are different stages of lymphedema. So it's very important to understand what the basis, what the cause of the lymphedema is in the patient. It usually arises from, with breast cancer patients, the lymph nodes being removed in the axilla, in the armpit. It could be that one node's removed. It could be that various, depending on how many nodes are affected, if any, with the cancer. So if the cancer has spread into the lymph nodes. So we have to, those lymph nodes are removed. So it could be one. I have a patient at the moment, unfortunately, who had 22 lymph nodes removed.
Sure.
But that is not the only risk factor. Radiation therapy can increase the risk of developing lymphedema up to about 70%. And then the patient's BMI is another very, very important risk factor. So it's very important to assess the patient very clearly. But most importantly is also to educate the patient on what lymphedema is.
For sure.
And what the risk factors are, because we have found that the patients are much more compliant if they understand what is going on and how they can manage the lymphedema. As I think has been said previously, there's no cure for the condition. It's not a fatal condition, but if not treated, these patients land up with much discomfort. Secondary soft tissue changes occur, and they can lead to cellulitis, which is infection and inflammation, as well as pain, and the heaviness of the arm can begin weighing down on the shoulder and have effects on the neck because of the weight that these patients have to live with. So it's very important that the patient understands what we're doing and why we're doing it, and it leads to far more compliance in the treatment. When we talk about lymphedema in breast cancer patients, we're not only talking about lymphedema of the arm, but those lymph nodes under the armpit drain the breast, obviously, and that's why they are checked to see if there's spread of cancer. So a lot of the patients who have had a lumpectomy, as we call it, just a segment of the breast removed where the tumor is, can land up with edema of the breast. And that's very difficult to treat. Well, more difficult because we can't bandage it like we bandage an arm or a leg. And also because the breast has no muscles, there's no muscle contraction that would help disperse the edema. So it's very important that we check the breast for edema. And those patients who've had mastectomies, we usually find that the chest wall becomes swollen. So that is also treated. So the first treatment, as I said, is more or less an assessment. The patient gets to know me as a therapist, I get to know them. And it's important also to ask the patient what their main concerns are, as well as what their goals are, because it's not, I have goals as a therapist. I want the best for my patient.
For sure.
But goals for patients also very relative, and it's important for me to fulfill the roles of the patient. So that is the first treatment. And it's more or less an assessment. We have a long chat. I explain to them, I go through a little bit of a biology lesson, the physiology and anatomy of lymphedema, that I really empower the patient that they can really, really have the best possible outcome from the treatment and the condition, because obviously it begins to bother them if their arm's very large, as far as the discomfort point of view, as a part of a body disfigurement, and already they've had some disfigurement with the surgery of, a mastectomy or a lumpectomy. So that's a very important factor. So we assess the patient, and obviously if the lymphedema is at a certain stage and they need to be bandaged, then we start bandaging them, and so we progress with treatment. Another important part of the assessment also is to check their range of movement and their muscle power, because obviously the more they move, the more the edema will be mobilized, and the stronger they are, the more muscle contraction. So that will also help loosen and mobilize and drain the swelling.
So look, it sounds like such a big, multifaceted approach that you need to take to treating the lymphedema. Like, I mean, we know there are other edemas that exist as well, and of course they require different type of treatment. But specifically, what are the treatment options that you would put on your hierarchy of treating it, especially for patients that can't get to a physiotherapist to get their treatments done and things such as that?
Home instruction, home instruction, home instruction. So getting them to understand what the problem is, that they know how to approach it. Teaching them self-massage is very important. Teaching them the correct exercises in a specific order to facilitate drainage, muscle contraction to facilitate drainage as well. Exercises pertaining not only to exercises that can do at home, but also some kind of sport-resistant exercises. Compression. So first we start off with bandaging. That's usually for about a month in the acute stage. And then when they can then start managing their edema more independently, we put them in a compression garment. And another thing for women is what they need to do to promote their self-treatment is to wear the correct bra, because wearing the correct bra is vital to support the operated breast, that there are no, for example, bones in the bra that dig into the breast that can make the edema worse in the breast. So that's very important. So teaching them the correct bra to wear, ordering them a bra. If it's a mastectomy patient, fitting them with a prosthesis that the prosthesis will compress the chest wall to facilitate drainage. And then also giving them sort of what I call the do's and don'ts of what they should and shouldn't be doing as to what the risk factors are that can aggravate the edema. So teaching them not to expose their arm to excess temperatures, extremes of temperatures. So no ice pack on the arm if it's sore, no heat if it's sore, because that will increase the circulation, make the edema worse. Never to have any injections, drips, or blood to be taken from that arm, because that can cause inflammation and make the edema worse. No blood pressure cuff on that arm, not to wear tight clothing on their arm, to avoid injury to the arm, like if they're keen gardeners, to wear gloves, if they're women that like to sew, to wear thimbles, if they're keen chefs or just have to cook that daily meal for the family, not to burn that arm, not to cut that arm.
For sure. So, Sue, I mean, it sounds like there are an array of things that you would obviously tell patients to go do at home. But I think the important points that you've highlighted here are that, you know, we have this thing called lymphedema. This is what it is. Don't be afraid to go out and go get checked for it. But of course, there are treatment options to make your life easier, establishing what makes the patient feel better and also just building them up to a treatment point where they would feel better. Thank you so much for joining us, Sue Cerebra, who's a physiotherapist and certified lymphedema wound care specialist. After the break, Zaba Buthelezi will take us through the latest South African COVID-19 numbers, and we'll speak to Dr. Marlon McKay as he answers questions on COVID-19 and the symptoms and any of the views that you've brought up on social media. Stay with us.
A very good morning to Vital Signs viewers. I'm Zamabu Telezi. We continue to observe a downward trajectory in the numbers of new COVID-19 infections across the country, but more hospitalization. While the new infections are lower, the deaths due to COVID-19 are higher as South Africa passes the peak of the third wave of COVID-19. Health experts warn of a fourth wave on the horizon. For now, though, let's take a look at the national COVID-19 statistics. Since the first case was recorded last year, over 15 million tests have been processed in South Africa. More than 2.5 million positive cases have been recorded. Over 2.3 million recoveries have been recorded. But sadly, more than 76,000 people have died from COVID-related illnesses, and we're sending our sincere condolences to their families. More than 9 million people have been vaccinated in the country. So what's happening in the provinces, the 7-day moving average daily number of cases has decreased. Gauteng remains the epicenter of the third wave of the pandemic, with the Western Cape continue to record a majority of new cases in the last 7-day period, followed by KwaZulu-Natal. For now, though, let's take a look at the infection numbers recorded. To date, over 800,000 positive cases have been recorded in Gauteng. Over 430,000 positive cases have been recorded in the Western Cape. Over 400,000 positive cases have been recorded in KwaZulu-Natal. Over 200,000 positive cases have been recorded in the Eastern Cape. The remaining provinces are also seeing a decline in numbers of new infections. While this is good news, it doesn't mean that the people should become complacent, as COVID is still around. We have seen what has happened in the past, where numbers just increased, sometimes significantly. And mind you, the Delta variant, which is more transmissible, is still around. For now, though, let's take a look at the numbers recorded. Over 134,000 positive cases have been recorded in the Northwest. Over 133,000 positive cases have been recorded in Mpumalanga. Over 130,000 positive cases have been recorded in the Free State. Over 115,000 positive cases have been recorded in Limpopo. Over 70,000 positive cases have been recorded in the Northern Cape. So vaccine registration is still open for those ages 35 and over. You are all urged to register and go out there in numbers to vaccinate to lower COVID severity and hospitalizations. Let us continue to take precautionary measures, and these include regularly washing our hands with soap and water, sanitize using sanitizers containing 70% alcohol content, wear a cloth mask that covers both our nose and mouth, practice social distancing and ensure proper ventilation indoors. Lastly, avoid mass gatherings. If you believe there is a chance you may be infected with the virus, call ahead to seek medical help from your healthcare provider or use the public hotline. It's a free number, 0800 029 999, and alert them to your symptoms. Remember, protect yourself to protect others and vaccinate. Back to you, Musa.
Thank you so much, Zama, for that update. This chat's right now to the one and only Dr. Marlon McKay, who is joining us again as we talk about vaccinations as well as COVID. So we're in that window, Dr. Marlon McKay, where, a lot of people are, getting into the mood of registering, going out to go get their vaccine. An important question to ask is, should you get a COVID test before you go get the vaccine?
That's a very good question. Good morning. So the data shows that it is not necessary to have a COVID test. I think it's overkill. The most important thing to note is if you have any symptoms suggestive of COVID-19, rather not take the vaccine. Rather self-isolate, wait a while, but don't come near the vaccine center if you have symptoms. But there's no reason to first have a test.
So a lot of people have been speaking about, their, let me put it this way, their experiences with regards to getting the vaccine. A lot of people really not really saying much. I know with myself, I got the jab and that was that. No headache, no back pain, no stress, nothing came up with me. But some people complain of having joint pain and headaches and things such as that. So what should people do to prevent themselves getting some sort of symptomatology post the jab?
Yeah. Okay. So firstly, the jab is not without side effects. As we know, any medication always comes with side effects. Okay, so that doesn't mean that all of us are going to get side effects, as in your case. So the most common side effect will always be a local side effect, which is right at the point where the needle is inserted. So you can have redness, you can have a bit of pain, a bit of swelling, a bit of a sore arm. We don't advise that you take anything prior to the vaccine, as it may inhibit the immune response. So if you do get home and there's a bit of pain, there's no problem taking some simple analgesia like paracetamol. Some patients may experience what we call more systemic side effects. In other words, where it affects the whole body, all your systems. So headache, maybe some chills, but a fever, almost like a flu-like illness. Again, it is usually mild. It is not COVID. The vaccine cannot give you COVID. And again, you just need some bed rest. You may feel tired. Again, just take something for pain. It's transient. It may just last a day or two, and then it's over. And that's it for the vaccine.
Okay, so a question from Beverly Dazel here saying that since yesterday I've been experiencing severe leg pain, a sore throat, headache. This morning I woke up at 4 a.m. with excruciating leg pain. I had the J&J vaccine 3 weeks ago, and I think I'm getting flu. Did anyone experience these symptoms? So is this the end of the scale sometimes of getting the vaccine, or what do you think is going on here?
So it's very unlikely, Doc, that this is related to the vaccine. The vaccine, in terms of side effects, is usually 24 to 48, maybe 72 hours after the vaccine. This is at least 3 weeks. The good news is that our viewer has now full protection. Your regard is fully vaccinated against COVID. However, we know that there can still be breakthrough infections even with the vaccine. Okay, so if you're having these symptoms, my first guess is provisional diagnosis is actually COVID, and especially with the Delta variant, we've seen a lot of this body aches and pains, leg pain, low back pain. And based on your symptoms, please don't think it's flu just yet. It's worth your while getting a COVID test. The vaccine did not give it to you. You are still at risk of getting COVID, especially with the Delta variant. So please rush out and get a COVID test. Let's make sure you don't have it. And if you do have it, let's treat it urgently.
So a lot of people will say, and these are not my words, and people will say that, I've gotten the vaccine, I am immune from getting COVID-19. Is that true?
That is not true. Remember, no vaccine, and in particular the COVID-19 vaccines, the vaccines do not grant you immunity against getting COVID. The protection comes in. If you do get it, it will be mild or asymptomatic, but the bulk of the protection, and this is why we want everyone to be vaccinated, it reduces your risk of severe illness, hospitalization, and death. So we don't mind you getting COVID because you'll have a mild infection. So please don't think that if you are fully vaccinated that you are now immune. Nobody is immune, and I think you and I can both attest to that because I've had COVID on top of my vaccine.
So another question from Kim Lily saying that we got our results back. My 5-year-old son and I are positive. We are both asthmatics, so I'm on edge. What now?
So it's actually very interesting. Asthmatics and COVID is not regarded as a severe comorbidity for serious illness, provided, of course, your asthma is under control. Provided, of course, you are using especially your preventer pump or your controller pump, and you have your reliever pump close by. So keep the asthma under control. There is no reason to be extra stressed about getting COVID because you are asthmatic. However, still watch the breathing, watch your cough, watch for any chest pain, and keep on with your asthmatic medication throughout your illness.
Very important to control that asthma, isn't it? So let's get into the next one. It's an interesting one. A lot of people advising others to take preventative or prophylactic medication after they get their vaccination. Is this something you'd advise?
No, this is the whole point about having a vaccine, because the vaccine, I just had a question like that on Facebook now. The vaccine itself is your best preventative measure. So there's nothing else that you need to take because the vaccine will do the job. The only thing, as Zama has been saying, please don't think that you are immune. So basic principles still apply. Wash your hands, wear your mask, keep your windows open, and watch your distance. The 4 Ws.
And the last question I think we'll take today from Dikeledi Sikumba saying that it's been 15 days since I tested positive and I have difficulty swallowing anything from food to water. It feels like something is stuck in my chest. Has anyone experienced what I'm going through? Is this something commonly found, or should this person really go see their healthcare provider?
No, it's not that common, but you do see it. And it could be from severe throat inflammation. Also, with all the medication and with COVID, you get a lot of acid reflux, and that could be exacerbating it. I'm just concerned about the difficulty in swallowing, so it may be worth your while just to visit your healthcare practitioner to exclude anything more serious.
Well, thank you so much, Doc, for joining us today and answering all those questions. Joining us weekly, Dr. Marlon McKay, who answers all of your COVID and, I guess, other related questions. Well, that is the end of our show. Thank you so much for joining us and watching Vital Signs. Don't forget that the only way that you can manage this pandemic is making sure that you are playing safe, vaccinated or not. If you can stay at home, stay at home. Social distance, wash your hands, wear your mask, and don't do anything that will put others at risk. I'm Dr. Musam Tombeni. Do take care.